Still V-fib, nothing.
Charging. 19 seconds.
Charge to 300.
300. Anything? 27 seconds.
Charge to 360. Come on, Katie.
49 seconds.
At 60 seconds, you're supposed to admit another
Charge
drug.
again. Charge again.
Of course, though, it is TV, so she's gonna live even though she's been given enough power to supply a small village. Grey's Anatomy has been running for 19 seasons and has been nominated for 4 Emmy Awards. It's one of the longest running and favourite medical dramas of all time. Let's see if it lives up to the hype. Make sure to watch till the end for my verdict on its accuracy and entertainment value. With that being said, let's get into the video.
This is...
Humiliating on so many levels. You have to go.
Why don't you just come back down here and we'll pick up where we left off?
This is the opening scene. I thought I was watching Grey's Anatomy, not 50 Shades of Grey. To be fair, if I learned anatomy this way, maybe I would remember it better.
A month ago, you were in med school being taught by doctors. Today, you are the doctors.
Now that is an introduction. We need to do epic battle speech training in med school so we can get this in hospital. When I started, it was like, here's the bleep, good luck, you're gonna need it.
I have 5 rules, memorize them. Rule number 1, don't bother sucking up. I already hate you, that's not gonna change. Trauma protocol.
Now that is much more realistic, I have to say.
Cindy Bryce, 15-year-old female, new onset seizures, intermittent for the past week. IV lost en route, started grand mal seizing as we descended.
Well, the first thing you'd want to know actually is how long has this seizure been going on for? Because they said it started as the helicopter descended, which means it's probably less than 5 minutes. If it lasts longer than 5 minutes, it's something called status epilepticus, which is much more dangerous, and you would want to treat more aggressively. But let's see how they manage it.
All right, get on her side. Is it 10 milligrams diazepam IM?
You see, lorazepam is usually used first line instead of diazepam. Diazepam actually works quite quickly, but only lasts 15 to 20 minutes in the brain because it redistributes to the rest of the body quite quickly, while lorazepam's effect lasts about 1 to 2 hours, which means that it's more successful in terminating seizures. And we don't commonly give diazepam as an injection. It's more commonly given as tablets, and usually for someone who you want to prevent seizures rather than treating them.
I heard every year the attending on call picks the best intern and lets them perform a procedure during the first shift. I'm just saying it's what I heard.
Go away. Now.
See, as an intern, it can be very hard to get surgical experience because your attending basically takes responsibility for any of your patients. They need to be able to trust that you're not going to mess anything up, and that takes time to build up. Now, if you're having surgery in a teaching hospital as a patient, you might not know that actually it's quite likely an intern will be doing some parts of the operation. Usually that's more minor parts like opening the skin and closing the skin, although those are the parts that you see when you wake up from your operation, so they need to really be done carefully, and usually they are supervised. So I've closed some skins. I haven't had any skin infections yet.
Thank you, Jesus!
Even as an equivalent of an intern. So, you know, I do think it's good quality. If anything, they take a little bit more care and time to be able to do it, although that sometimes doesn't equal end result.
Okay, so I'm just gonna insert my fingers into your rectum.
Fingers? Only one finger needed. And why have she got him with an open window directly behind him? This is not the time for audience participation. And okay, the position is not rectal exam position. This is 50 Shades position. For rectal exam, you want them on their side with the knees all the way up. And it's such an intimate exam. The patient's really nervous. Privacy is so important for that. She needs to do better. Now she decides to close the curtain.
They gave her a sedative for the CT scan, so she's a little groggy.
Will she be all right?
Our doctor at home said that she might need an operation. Is that true?
What kind of operation?
She's, well, you know what? I'm not the doctor. I'm a doctor, but I'm not Katie's doctor, so I'll go get him for you.
When you see a doctor backpedaling like that, just let them go. They were never meant to be there in the first place. But honestly, when you first start, speaking to families can be quite terrifying because there's so many things to learn. You actually don't know the patients or even the management that well as an intern. So you get things mixed up frequently, and it's actually much better to get a senior doctor to discuss to avoid any mistakes. And so Meredith did quite well here. Gold star.
It's off the case. Katie belongs to the new attending now. Dr. Shepard, he's over there.
All right. That's nice.
Of course, the man from the morning is her attending. What a plot twist. Relationships in the workplace are very common, and sometimes the way people are connected is quite interesting. One of my old workplaces, there were two separate respiratory attendings who were female and gay, and they both had the same anaesthetist as the sperm donor for their children. He was basically the Genghis Khan of our hospital.
Dr. Burke.
Get out of the way. Pansy-ass idiot. Get him out of here. Suction. Clamp.
007. 007, yep. A total 007.
It's 007, mean.
License to kill.
Things can get very sharp and heated in the operating theatre. I was once assisting on a thyroid cancer case that was invading down into the superior vena cava, which is one of the huge blood vessels inside the chest. And as we were removing the thyroid cancer, we actually tore open a hole inside that vessel, and basically I had to keep it tamponaded with my finger on the vessel until we managed to repair it and stop the bleeding. In situations like that, please and thank you, go out the window very quickly. And it might look sharp, but it's just with such a high stakes environment, these things do happen.
What did you just say? Did you just call me a nurse?
Oh, the white cap fits.
Whoa, okay. I hate it when this happens. It's really a common problem for my female doctor colleagues that patients or even sometimes staff just think as though a female doctor is actually a nurse. I just want to make it very clear, being a doctor or a nurse has no gender prerequisite. Actually, most graduates from medical school are female now, more than 55%, and in some med schools it's over 65%. So let's get rid of that old school mentality and nip it in the bud now.
Dr. Gray, you need to tell us what you want to do. Heart stop.
Call blue! Call blue!
I'll get it. Right away.
Wait. Charge pals to 200.
Charge. Clear.
Whoa, okay, so first of all, this is not accurate at all. When there's a cardiac arrest, you need to basically confirm that it's an arrest, and then the first treatment you give is starting chest compressions. Second of all, she just shocked the patient with oxygen on the face, which is flammable and potentially a risk that could blow up. Before you deliver a shock, you need to tell everyone to move the oxygen away. The other thing is that she just indiscriminately shocks the patient without checking what rhythm it is. You need to shock either ventricular fibrillation or pulseless tachycardia, and she's also shocking half on the clothes, half on the patient, and clothes are quite insulating, so I don't even think that this shock would be delivered properly. But let's see what happens.
Still VFib, nothing.
Charging. 19 seconds.
Charge to 300.
300. Anything? 27 seconds.
Charge to 360.
Come on, Katie. 49 seconds.
At 60 seconds, you're supposed to admit another
Charge
drug.
again. Charge again.
Wow, 4 shocks in less than a minute. You need to wait at least 2 minutes between shocks, and that reason for that is it's been proven to actually improve the outcomes from a cardiac arrest situation. And of course, though, it is TV, so she's gonna live even though she's been given enough power to supply a small village.
Oh, I'll be outside the aura the whole time. No, Dr. Burke is very good. Don't worry. I'll see you after.
He'll be fine, right?
Tony's gonna sail through. You have nothing to worry about. Promise.
He promises? How can he promise that? He doesn't know the future. Oh, you have to be so careful with that. So you can give reassurance, but it has to be measured with understanding of risk, especially if someone's doing a procedure under general anesthetic, and that always carries a risk, even if it's small. I hope this doesn't come back to bite him, but I suspect it might.
I'm working hard on Katie's case.
No, you're not. If you were, you'd be able to give me some answers.
Whoever finds the answer rides with me. Katie needs surgery. You get to do what no interns get to do. Scrub in to assist on an advanced procedure.
Wait, my big question is, why is a surgeon asking surgical interns for help on a neurology question? So surgeons are good at cutting and diagnosing surgical problems, and not necessarily at figuring out the cause of a complex case of epilepsy. And the second question is, how does he know that the patient needs surgery when he doesn't even know what's causing her seizures? And you may not have seen, but all of her scans and her lumbar puncture tap have been negative up to this point. And so what would he be operating on? I mean, there are only very few things that cause recurrent seizure that actually would need surgery. And they would be things like aneurysms, brain bleeds, or cancers.
It was a fall so minor, her doctor didn't even think to mention it when I was taking her history, but she did fall.
Well, you know what the chances that a minor fall could burst an aneurysm? 1 in a million, literally.
Seems like they've got it. Aneurysms are actually more common than you might think. Between 1.5 and 5% of people actually have an aneurysm, but less than 3% of those actually ever experience any symptoms. And those are things like sudden onset, severe headache, neck stiffness, sensitivity to light, and also reduced consciousness and recurrent seizures. There are some things that it's associated with that are not preventable, like genetic diseases, Ehlers-Danlos syndrome or Marfan syndrome. Some are preventable. Things like high blood pressure and low activity levels, smoking, excess alcohol consumption. It's usually diagnosed using a CT scan, which will pick it up, or a spinal tap, which picks up some bilirubin that stains the color of the fluid, which is usually clear, a yellowy color. And in the olden days, people just used to look at it, but now they've got a spectrophotometer which actually measures and can pick up almost 100% of all burst aneurysms through that way. It's very sensitive, very specific. Other tests, you can inject a dye into the veins, and that goes up into the brain and shows you all the vessels, and if any are bleeding, you'll see the dye leaking out when you do a CT scan. And then to be able to treat it, once you know where the actual aneurysm is, you can put a long tube through from the groin or the thigh up into the brain, and you can coil or clip off that bleeding artery, which means that the person can avoid brain surgery. Moral of the story, if anyone that you know or yourself has any symptoms of a aneurysm, then seek urgent medical attention, because early intervention means better outcomes.
Wow, that was quick.
His heart had too much damage to get him off a bypass. Had to let him go. It happens rarely, but it does happen. The worst part of the game.
But I told Gloria that he would be fine.
This is why you don't promise. Oh, that's a hard pill to swallow for him. I've been lucky enough to never have lost a patient on the operating table. Some of my colleagues have not been so fortunate, and telling the family afterwards is one of the hardest things to do. As doctors, we take oaths to do no harm, so we take it personally when we lose a patient, especially thinking about how their family is going to cope afterwards. Not much you can do, really.
Tony died. He's dead. Gloria, I'm so sorry.
Oh man, is he really delivering that devastating news? Stood up in the middle of a waiting area. Breaking bad news is one of the hardest things to do, and there's not much you can do to soften the blow, but some small things are taking someone to a private room, offering them a tissue, making sure their family are there to look after them afterwards. Not doing it in a packed waiting room where everyone else can hear the conversation. If a doctor tries to deliver news to you like this, insist on going to a private room.
All right, everybody. It's a beautiful night to save lives. Let's have some fun.
I can't think of any one reason why I want to be a surgeon. But I can think of 1,000 reasons why I should quit.
One of the most important parts about being a surgeon is actually knowing when to operate, and I'm not sure why they're cutting open the head when they have the option to coil this endovascularly. You'd only really want to open if that had failed, and it doesn't seem like it has already. Why have a cut in the head and a huge scar when you can just have a small cut on the groin? She did raise an interesting point though. Being a doctor is really not easy. It's not for everyone. They say that it's a calling, but for many it really isn't. They go into the profession because their parents want them to, or because of the idea they have of a hospital based from medical dramas, or for status or money. Not in the UK because we're not paid anywhere near as well as they are in the US. But these are all really bad reasons for being a doctor, and I think part of the reason why training is so hard is basically to help people understand if the career is really right for them. I mean, for me personally, I find it so satisfying seeing my patients get better, and that's part of the reason why I chose to do family medicine, so I can follow up patients afterwards, and that has kind of carried me through all the hardship, paperwork, politics that I have had to get through to get to the position that I'm in now. But not many actually make it past their training.
So, I made it through my first shift. We all did. The other interns are all good people. You'd like them. I think. I don't know. Maybe. I like them.
Doesn't that just make you all warm and cozy on the inside? To be fair, you know when you first start, because everyone else is in the same position, you have that bond of suffering that you go through that makes you close. You can kind of only compare it to something like the army, where, you know, there's a ranking, but then you have like your brothers and sisters in arms, and that's really what it feels like. So you do have a good social support around you when you first start, and I've made some really good friends through being a doctor as well. Although I don't know where they are now because I'm sat on the room on my own chatting to you, but you're all I need for now.
Thank you.
And that brings this to an end. I think entertainment value is very high on Grey's Anatomy. I'd give it an 8.5 out of 10. Accuracy, I'd say 3.5 out of 10. There's a lot that could have been improved. House is definitely much more accurate and intricate from a medical perspective. So if you do want to see me reacting to one of the House episodes, I've got the episode voted best as the 3 stories one. It's going to pop up on your screen here. Check that out. Otherwise, I hope you've enjoyed the video. Let me know in the comment section below if you have. Hit the like button as well so more people can see it and be educated. I wish you a lovely day. Stay healthy, and I will see you in the next one. Take care.